Good morning, everybody. Thank you for being here with us. I appreciate it, given that, as I said, it's about 100 degrees for about the 15th straight day. So thank you. It will be well, I assure you it will be well worth it. We have some wonderful presenters today with some really interesting new information for you. But we will begin, as we begin every month, talking about where we are in terms of what we are seeing across the county in terms of the fatal overdoses that we respond to, we being the state police assigned to our office. And again, beginning with the fact that us responding to even one death is too many, it is important for us to be looking at where we are, engage how the impact of our work. So last year, this period of time from January to July 10th, excuse me, of 2023, we had responded to 106 non-suicide opioid overdose deaths. And we had responded to 9 suicide deaths with opiates. And remember, when we classify something as someone died by suicide, it is abundantly clear. So there probably are more of those in those numbers, but for many reasons, we do not make that assessment unless there's all kinds of evidence that that person has died by suicide. For the same period of time this year, in really what, again, considering that one is too many, really a pretty dramatic set of numbers, we have responded to 73 non-suicide fatal opioid overdoses. That's a 32% reduction, which, if you've been following sort of the statewide numbers, is significantly higher. And I am certain that much of that is due to the work of the people who so faithfully join us here and are out in the field every day doing that work. Now, concerning is in that same period of time, we have responded to 12 clear situations where people have died by suicide. So that is a 33% increase. So almost yin and yang in terms of numbers. So, and that has been true certainly since the beginning of this year. We've seen our responses going down, has been hovering in the 20%. We're up to 32, but we have continued to see those deaths by suicide increasing in a fairly dramatic number. And, you know, we use a ratio in terms of thinking about impact. It isn't just the people who either die by suicide or who die from an overdose. Using a really conservative number, that 10 people are impacted by that death, the work that's being done in reducing those numbers increases an exponentially larger pool of people. So that's very important for us. And there's no question that much of what is happening in this county is based on the fact that we're coming together. We are staying abreast of the trends, and we are making resources available to everybody. So people aren't spending time reinventing the wheel or spending money on the same thing when they can get it somewhere else. So you may have seen, pretty interestingly, Boston Globe recently ran an article on June 17th that said that in 2020, individuals who had suffered a drug overdose and were Medicare patients were significantly more likely to later receive an opioid painkiller in some other medical care rather than something that would help them in their struggle for addiction. And a significant number of those folks ultimately died from an overdose. So they have an overdose, they're getting medical care, there's a lack of attention to, or enough attention to what might be prescribed for them, particularly if they are Medicare patients. Now, Medicare has since expanded its coverage to include methadone to address that treatment gap so people can be prescribed that. But that study is a reminder that the full range of treatments is not always available to those most in need of it. Because clearly, if you were a Medicare patient, you were not eligible for some things. Also, a continuing recent topic of conversation has been the use of Narcan, particularly around high schools, and an encouragement, despite some parental pushback, that everybody should be being trained, like CPR, like how to use a defibrillator machine. Everybody should be being trained, and training your kids in how to use Narcan is not encouraging them to use drugs, but is helping them to be aware in certain situations that they could be helpful to people. So as a result of that, we have seen a number of schools now moving back towards stocking Narcan. And I remind people all the time that early in our work, our office has been supplying Narcan to anybody who wants it, including schools. And when we first started doing that, I would see an amazing amount of Narcan going out to schools and being used because they were coming back for replacements. And I was really concerned at some point. I mean, elementary schools were using a lot of Narcan. What we discovered, particularly in the more rural parts of our county, was lots of people who maybe they were with somebody who was experiencing an overdose, and they thought of a school as a place, there's a nurse, I might be a fair distance from a medical facility. While I'm driving the person who's experiencing the overdose, I'm going to pull into the school driveway and see if they can help. And schools were helping. So much of their use was going to people who weren't a part of their community in any way, but they saw the flag outside, they believed there to be a nurse inside. We have parts of our county where it's a good drive to a medical facility. So they were taking advantage of that. We are going to again return to doing what we've done in the past. Dr. Dan Muse, who's an emergency room physician and a great battler against addiction, has in the past done trainings for us with school nurses about the use of Narcan. We'll be doing another one of those before school starts this year. And in an interesting continuation of a conversation we had here many months ago, you may remember we had the Harvard students who came, and they were busy trying to create a project that would cause the T. They were focused on the red line since it goes to Harvard Square, to stock Narcan in subway stations. The MBTA has now agreed to have Narcan at 5 stations based on the numbers they have seen. So their Narcan will now be available in an unlocked box with 2 doses in each box at the Quincy Center Station, Ashmont, Andrews Station, South Station, and Harvard Square. So they are implementing that. We heard about that kind of a long time ago. So they've finally gotten that to a place where the T is funding it. Also, we have been following the information that shows us that the numbers of overdoses continue to rise in a disproportionate way in the Black community. The Globe recently noted that fatal drug overdoses among people of color in Boston had risen 125% in the last 5 years. And we'll put all those articles and statistics in the chat. And it also is a good segue to the work of one of our presenters today, Dr. Barnett, who has really researched racial inequality in receipt of medication for opioid use disorder, and why that is so incredibly necessary, and why we really need to be paying attention to that. Now, turning to our first speaker today is Tiffany Foster. Tiffany is a volunteer manager at the New England branch of the Phoenix. For those of you who've been with us for a long time, you remember we learned about Phoenix in those long ago days before the pandemic. And it's a nationwide nonprofit whose mission really is to create a sober, active movement led by volunteers that are using the power of community and how transformative that can be to foster a sense of safety, of inclusivity, and fun. They have reached over 427,000 people. They've hosted in excess of 122,000 events, and they have 2.9 thousand volunteers. And you remember that when they came to talk to us, they talked about the gym programs, things that they were hosting, rafting and climbing, and all the things that people could do knowing that their sobriety would not be sort of threatened by who they'd be with. And Tiffany is a person in recovery herself who has really taken her own experiences with homelessness and being impacted by the criminal legal system to this work. And she's excited to be here. She told me earlier to talk about a new initiative that is going to support justice impacted individuals, bringing the Phoenix classes inside the jails and other houses of institutions, and really create a supportive community for folks that are going to be making a reentry. And remember, we always talk about, virtually everyone who goes into the criminal prison system in Massachusetts, House of Correction or prisons, is coming back out. So it's important to be, regardless of why they're in there or how long they're in there, it is always important to be focused on that reentry piece. So Tiffany, welcome back. We're happy to have you here to talk about that.
Thank you so much. Yeah, I am super grateful to be here, and thank you all for being here as well. The Phoenix has gone through a bunch of changes since the pre-COVID days, for sure. And with one of those changes, we became a volunteer-led movement. So historically, it was a really held close to us, and it was Phoenix staff putting on programming. And we realized that to reach the amount of people that we need to reach, we had to let go a little bit. And now over 75% of our programs in the Middlesex County are led by volunteers. And we have grown so much, and thankfully we have the space at the Middlesex County Sheriff's Office in their community counseling building that has a small gym where we hold programs. We also have a ton of partnerships throughout the Middlesex County with other gyms and volunteers leading hikes and all of that stuff. And if you want more information on like the programs that are open to everybody in the area, I can connect with you. I will leave my email in the chat, but I would really love to talk about our new criminal legal program. We have received funding and are super excited to really get this off the ground. I am currently leading programs inside of the Women's Reentry program on the Billerica House of Correction. So we have fitness and yoga happening every Friday there. We are also in the Framingham State Prison, where I'm leading fitness every Tuesday. And it's probably one of my most favorite classes and group of people that really need what we have. So our whole program is going to be in 3 different components. So one will be support within the correctional settings, which has been kind of difficult to make happen. There is a lot of, different procedures and rules and stuff that we have to figure out. But we are doing that with both staff, volunteers, and contractors. We will also have community-based support, so partnerships with other organizations that are already doing this amazing work. And our third piece is pretty cool. Part of the Phoenix's mission is to reduce stigma around substance use disorder. So we are collaborating with correction officers and staff to provide trainings. I will be leading some of the Middlesex Sheriff's Office cadet workouts. So they will be exposed to Phoenix, exposed to somebody who has recovered from substance use disorder, because that's not always what they will run into, and just lessening stigma around that. So we believe that the Phoenix nurtures a supportive community and offers essential resources for justice impacted individuals. Sorry, I'm reading. Striving to overcome substance use disorders, rebuild their lives, and thrive. We will work with the local sheriff's office, problem-solving courts, prisons and jails, community corrections programs, and mission-aligned organizations to engage people in sober community throughout their incarceration and welcome them into the broader Phoenix movement as they're released. So the whole idea is that it's really hard to just walk into a gym facility as a normal human being. Well, not normal, but that's not a real thing. It's intimidating, it's scary, and what we want to do is have a space where formerly incarcerated individuals feel welcome and a part of a community. So by going inside and introducing the Phoenix to them while they are there, it will make it easier for them to come out and plug into a safe and supportive community. We know that humans connect. That's what we do. And addiction is just a connection to something that is not positive for us, but it does its job. So we hope that when people are re-entering, they can connect to our safe and supportive and welcoming community, instead of connecting to what they are used to, and what they might have access to, because while we're doing really amazing in, you know, providing reentry services more so than in the past, we still need more. And that is what the Phoenix is trying to do. So we are going to be training volunteers while they are still incarcerated and allowing them to lead Phoenix programming and develop skills. And then upon re-entering the community, we will be able to assist in training and hopefully jobs and all of that, and being a leader in the community and having a leadership role, really. I don't know if I've missed anything. I get nervous when I present, so bear with me. And yeah, I think, do we have a website for the Phoenix? The Phoenix is thephoenix.org. And really the best way to access the Phoenix is through our app. We have an app on your Play Store or your Google Store, which will show you any Phoenix events in your area, as well as everything we have virtually, which is from like 7 a.m. to 9 p.m. We have partnerships with Recovery Dharma and CCAR. So there's meetings, there's meditations, there's yoga. And thanks, because that just sparked what I missed. We also have Phoenix programming on the Indovo tablets that are in over 44 states throughout the United States. And those are inside jails and institutions. So we have on-demand Phoenix programming that people can access and get introduced to the Phoenix as well. And we've served over 100,000 people with that. So part of our initiative is to get that into all of the jails and institutions in Middlesex County as well. I think that is all I have, other than we are always looking to create new partnerships with organizations that are doing this work. I'm the program manager on this and will be, within the next year or so, trying to create a large reentry fair in the area. So if you are passionate about this work and or know anybody who is, I would love to connect with them. We have a male contractor and a female contractor, both with lived experience. That's a huge part of the Phoenix, is that our instructors and our leaders are people who have experience in the criminal legal system and also with substance use disorder, and they are the ones running this stuff. So we're always looking for more people to come along in this work with us. And yeah. thank you for letting me share.
Tiffany, thank you. Anybody have questions, comments?
Just a quick question, Tiffany. Have you seen, or maybe the program's relatively new, has there been a good transition from those that have been trained, become instructors? You talked about the leadership skills translating into like maybe studios or somewhere where they then move on to a gym or somewhere else. Have you been able to see that transition, or is that a hope for part of the mission?
That is a hope for part of the mission. So we actually, in this new program, it's very new, so we haven't had anybody re-enter and come into the community yet. We're only in our first, I would say, 10 weeks of it. But our previous program that we had pre-COVID, before we weren't allowed inside, we had a woman who came from the women's reentry program, was running workouts in the house. We got her a grant through Mass Hire to come on as a Phoenix employee, really, for a certain amount of time, and she was able to get her CrossFit level 1 lead classes in the community, and actually went on to become a recovery coach and is working with the DOC in Michigan now. So there's a huge success story there, but we don't have her in Middlesex County, but it's still a success.
Anybody else? Tiffany, thank you.
Yes, you're welcome.
Thank you. All right, we are, as I mentioned, also very happy to have with us this morning Dr. Michael Barnett, who is an associate professor at the Department of Health Policy and Management at Harvard's T.H. Chan School of Public Health. Dr. Barnett is a health services researcher and primary care physician. His research centers around the understanding and addressing the inefficient delivery of healthcare in the United States, whether it is in settings like a doctor's office, a hospital, a nursing home. How are we inefficiently doing that? I think we all know there's a lot of inefficiencies to look at. Dr. Barnett is joining us today to share about his work in racial inequality and stigma around medications for opioid use disorder. So, Doctor, thank you for being with us today.
Thank you for having me. Let me share my slides here. Everyone can see okay? Let me open up the chat window also. And people, I mean, I guess I know it sounds like the typical format here is like maybe a 15-minute talk followed by questions, but feel free to put questions in the chat, or, you know, I'm okay with people just unmuting and just asking questions if there's anything they'd like clarification on. All right, so the talk today, I'm largely going to walk through one of our recent papers that looks at racial inequality and access to what I call MOUD, medications for opioid use disorder. It brings up a lot of themes that I think have already come up today and touches on, and I have lots of other research that touches on many of these themes. So I'm happy to have a wide-ranging conversation that kind of branches off from the results I'm going to be presenting. And clinicians, we often do the conflict of interest part. I'm an expert witness in litigation against opioid manufacturers. So I don't think this audience needs much education on the pattern of overdoses across the country, but I would like to point out that before the pandemic, there was a rapid closure in this white-black divide in opioid mortality, which was not one of the reassuring changes in disparities. This was one where basically the Black community was experiencing increasingly worse outcomes and catching up to the white overdose rate involving opioids, which used to be much higher. And this wasn't really reflected in other major overdose categories like cocaine and other psychostimulants. And during the pandemic, what we observed is that actually for the first time in many decades, the Black overdose rate involving opioids actually surpassed that for white Americans and accelerated even further. Unfortunately, we actually had kind of a leveling off of the acceleration of overdose rates in 2018 and 19, which is largely shown with the white group here, because it's by far the largest group. And the pandemic kind of erased any gains that might have represented. So, you know, a lot of what we're doing is playing catch up since the pandemic. So the focus of my talk today is really understanding factors that could be contributing to this inequality and or clinical issues that we have to be aware of to better attack this worsening disparity. I'm sure, of course, folks on this call are well aware that a major public health challenge is that there's this really, there's this huge drop off, this huge voltage drop among the population who's diagnosed with OUD versus those that are ever engaged in care at all for any reason related to their addiction, and those who actually receive any therapy. And among those who do receive therapy, depending on the state you're in and where you are in the country, still a minority actually get actual opioid agonist medications for treatment. And there are strong racial disparities in use that have been reported. The study that I'm going to be describing is another descriptive study saying, you know, who gets access to medications for opioid use disorder by race. But what I'm going to do is try to do a deeper dive into other related data to explore some hypotheses about why this might be happening, and hopefully debunking some potential myths or beliefs that our data are just not consistent with. So the main study I'm going to be talking about, our big question is really, how does receipt for MOUD after an adverse event for opioid use disorder vary by race, and how this changed over time? Now, the focus in our study is we're trying to focus in on a very high-risk group of people who are experiencing an event where it should be abundantly clear to all clinicians involved in their care that there is undermanaged or undertreated opioid use disorder. So here, these are disabled individuals on Medicare. These will largely be people who are both in Medicare and Medicaid. And they're included in our cohort if they have what we call an index event, which is either a non-fatal overdose, some kind of detox or rehab admission, which could be considered a good outcome, but it does mark that this is someone who's struggling with addiction, or an IV drug-associated infection. A lot of what we see in the hospital are not necessarily fatal overdoses, but people who have endocarditis or some other kind of horrific infection from injection drug use. And I'm kind of flying over a bunch of methods here, but happy to answer questions if people want to know any more specifics. But here's kind of like the bottom line of what we found in our study. So, so after one of these events, so these are people who presented to an outpatient doctor or the emergency room or admitted for an infection or overdose or need for detox. We found that there was about Black patients are about half as likely to get any buprenorphine as white patients were. There were very low rates of naltrexone use, which is not surprising because naltrexone is very unpopular. And concerningly, this is a period of time when the X waiver was still in effect, so that many clinicians didn't legally have the ability to prescribe buprenorphine for addiction treatment. But that was never the case for naloxone. And naloxone, we also saw basically a disparity of similar magnitude to buprenorphine. The part that really concerned us, and is consistent with the study that in the Boston Globe article that came out last month using a different data set, is that people were actually more likely to get an opioid analgesic like oxycodone or morphine from a clinician than they were to get buprenorphine. And even more likely to get a benzodiazepine, which in some ways is arguably even more toxic, actually, and even more likely to contribute to overdoses. And benzodiazepines are one situation where white patients were overwhelmingly likely to receive those prescriptions. So one very important nuance in these data is we're studying the Medicare program. And Marian actually already mentioned this, but Medicare only started covering methadone in 2020. So when we published this study, we had just gotten access to data from 2020. And we could also look among this Medicare insured population, how did methadone change this observed disparity? At least in this population on a national scale, despite, I think, kind of prevailing wisdom, we didn't find actually that Black patients were on methadone more frequently than white patients, though Hispanic patients were more likely to be on methadone. But what we found is if you look at who's receiving buprenorphine or methadone in just 2020 to 2021, we saw the same magnitude of disparity. So, which is not surprising because methadone was, largely level across the different racial groups, but buprenorphine was definitely not. And let me also point out, by the way, that even though we are capturing what should be kind of, a sentinel crisis event or like a clear marker that someone is at very high risk for mortality, that only a minority of these patients are getting any access to these agonist treatments. Another important thing is that we looked at this based on, we stratified it based on who had some kind of prior prescription pill for any of these medications versus those that didn't. And what was obvious, and you can see based on the levels here, is that the vast majority of people that actually got any buprenorphine prescriptions or naloxone, they already had established care with a provider and were already getting those prescriptions. And so among people who came to the, among the majority of people who came to the emergency room and had no prior fill for these medications, only a tiny fraction of them actually left over the next 3 months had buprenorphine or naloxone filled. And far more of them, consistent with our other data, had an opioid analgesic or benzodiazepines filled. It's also not just about whether somebody got buprenorphine or not. What we can do is also look at those in our study who did get buprenorphine. So here are the numbers here from 12.7% to 23%. And even among those who did get it, within 180 days, Black patients received almost a month less of buprenorphine than white patients. So this is basically a marker of retention. Treatment retention we defined as basically filling the having the vast majority of their 180 days covered with buprenorphine prescriptions. And you can see that we actually have like a 50% difference. 30% of Black patients who received any buprenorphine met our criteria for treatment retention in these 6 months versus 45% of the white patients. Mind you, these retention figures are pretty sad also, but not different than what we expected. But the majority of treating addiction is hard, and the majority of people on agonist therapy are not retained over a many-month period. All right, so here's the part of our study that's a bit different than you might have heard or read elsewhere, which is what we also want to look at is after this kind of sentinel overdose or other addiction crisis event, how much were these patients by race in contact with other healthcare providers. So I'm sorry for the jargon here. E&M visits, these are just office visits. So E&M stands for evaluation and management. But basically what we see is that even though there are some disparities here, the vast majority of these patients are seeing a doctor in the next 6 months after this overdose event. And Black patients have fewer visits, but all of them on average are seeing a provider at least once a month. And if you look at it by PCP, consistent with other data, about half of those visits are with a primary care doctor, and the vast majority are seeing their primary care doctor during this period. And even though not that many of them are actually getting some kind of office visit where addiction is one of the problems that's diagnosed, a good proportion, about 1 in 5, are getting some kind of access to addiction treatment. And then we can also look at just for any cause, people going to the hospital for another reason. So for ED visits or acute care admissions to a hospital, the majority of these patients go to the emergency room yet again in this 180 days. But we still don't, but we still see the pretty abysmal rates of buprenorphine prescribing. And of course, many people go into the hospital. Not surprisingly, we see that the population with the lowest use of agonist therapy, Black patients, also have the highest overdose rate, whereas white patients have the lowest overdose rate in these 180 days. So how do we put this all together? So we, of course, observe substantial inequality by race in who fills MOUD after these events. But there are a few things that really don't explain what this disparity was. I didn't show this data, but if we control for basically where people live, it's not explained by, for instance, people in the South use buprenorphine a lot less, and there are more Black patients in the South. So, this is really an issue of, why, of regional differences, and that's not what we see. It is largely related to low use of MOUD, before people came in for these encounters among Black and Hispanic patients. And the kind of stigma around opioid agonist treatment that I'll be covering in a couple minutes doesn't really apply to naloxone, but we still saw the same patterns. And these disparities exist despite the fact that all of these patients have many, many encounters with the healthcare system, both office visits and acute visits over the subsequent 6 months. So it's not like a lot of these patients are disappearing off the face of the earth. They continue to see doctors, and they get prescriptions for high-risk medications at extremely high rates. So the takeaways that we present here are that we think there's some unlikely mechanisms for disparities that we should really keep in mind if we want to try to make a dent in this problem, which is, first of all, we can't really blame regions. I think, if we look at this in Boston or Massachusetts, we're very likely to find the same effect. I think there are papers that there are papers showing that. This isn't about inability to make contact with primary care providers or other providers, because we see almost all the patients have contact with providers in this 180-day period. It's also not because people can't get prescriptions, because a large portion of this group are filling actually prescriptions that are pretty dangerous for them, as well as other prescriptions. And even among Black patients who do get buprenorphine, we see that they're still not retained as much. So those are people who have demonstrated that they can get buprenorphine, but they fall out of care much more quickly. It also doesn't seem to be related to, say, much lower use, say, among Hispanic or Black patients and white patients. There are some small differences here, like 6.6 versus 7.6 average visits over 180 days. But I'd argue that I don't know how clinically meaningful that difference is. It's still a lot of visits, a lot of opportunities. And then also another thing that doesn't explain this, and part of the reason we picked this particular population in the study, is that all of these people are really sick and clearly need treatment. So appropriateness, like who does and doesn't need it, is really not on the menu here. All of these patients have a severe enough presentation that we can see in our data where there shouldn't be a contraindication for them getting this. We think that the more likely explanations really probably cycle around stigma. I'd really like to focus on patient and provider level stigma here. So for provider level stigma, it could be that within provider, they're less likely to offer therapy to Black and Hispanic patients. And it also could be that, say, minority serving providers just have lower comfort levels. So maybe not that, like, me as a white male patient, I have either implicit or explicit bias and am more suspicious about prescribing opioid agonists to my Black patients versus white patients. But it could be that PCPs who are serving minority communities, healthcare is very segregated, especially in Massachusetts, that they actually are less interested or comfortable prescribing this. There's also patient level stigma, which is that there is qualitative evidence out there, less than we should have, that Black and Hispanic patients may have less trust in MOUD as a treatment for addiction. So they may not want it, right? They may know it's there, but they may not actually want it. After I published this paper, I did an interview about it with a Black talk radio station in Philadelphia. And I was excited to kind of talk about my study, but what we ended up doing for 15 minutes was just arguing over whether or not MOUD was important to take. Like, shouldn't people just, isn't this a choice? Like, people just need to, show up to rehab and get clean. And I was pretty surprised. And, it's just one anecdote, but I think it's not a coincidence that, I had that experience. There are other structural barriers as well, like physical access, public transportation, awareness and education, health literacy, things like that. So I want to dive a little bit more into stigma. So there is quite a lot of research on stigma out there, and I just want to give folks a little taste of what stigma looks like. So, for example, in the primary care clinician population, when people interview primary care doctors about, do you want to treat substance use disorder, a very, very common responses would be that it would change my patient mix, which of course is a euphemism for I don't want these people in my practice. They're manipulative. They're going to scare away my other patients. They're difficult. The prescribing is too complex, right? These are not attitudes that they would apply towards other complex conditions, right? Depression is complex to treat. Diabetes is complex to treat. right? It's really about addiction itself as a condition and the stigma, not that it is clinically so much more thorny or dangerous even than other conditions we treat. And there are a lot of beliefs out there which are still very widely held that I think that providers use as rationale for not prescribing things. So for example, that buprenorphine is more dangerous than other management that we do, which is not true compared to say insulin or anticoagulation. Use of buprenorphine is just a replacement addiction, which is also a very misleading way to put it because, it's not an addiction if you're taking buprenorphine every day and you can actually lead a normal life. An addiction is having to compulsively pursue anything, including a drug, despite causing great harm to yourself and others. And taking buprenorphine every day and having a normal life is not that. Also, abstinence-based treatment and detoxification are not effective, but opioid agonist therapy is effective. And then also prescribing buprenorphine and treating addiction are not necessarily more time-consuming and burdensome than other things we do in primary care. But that's also more of a policy fix that if we just paid more for it, people would do it. I also want to bring up that, we did a secret shopper study of residential treatment facilities where we tried to call them up and we posed as a young, uncomplicated patient who was looking to get to be admitted for detox. And one part of this secret shopper study that you're very surprised to hear is that 20% of the facilities, the person who answered the phone and tried to book our appointment made it abundantly clear that they actually think that taking opioid agonist therapy, or OAT here, is a bad idea. Not just that they don't offer it, but that you shouldn't do this. I'm going to discourage you from being interested, that it's not clean, that it's trading one addiction for another, or that somehow this treatment is addictive. And we found that, even for example, Joint Commission accredited or CARF accredited facilities, it didn't matter. They were just as likely to discourage this kind of treatment as other places. And this is an explicit manifestation of stigma. Okay, so to wrap up with policy implications, for me, the big takeaways here are that simply increasing contact with health providers is unlikely to be a solution because we really have to deal with stigma among healthcare providers, I think, if we're going to deal with this, because it's really about who's willing to prescribe and segregation and stigma. And then also, if we want to improve MOUD availability among minority populations, we need to target the doctors who are treating them, which is not people at MGB, right? Or, it's like, for instance, Boston Medical Center, their patient population is 55% Black. And in Mass General Brigham hospitals, it's 7%. So we really need to target the providers that are serving minorities because Boston is a very segregated city. And then also we miss a chance to help people transition to care when they come to the emergency room. And we should, educate providers more about these touch points and how we can guide people to therapy as much as possible. And then lastly, and this again was talked about in this meeting in the very beginning, so that naloxone availability is probably the lowest hanging fruit. And it sounds like this group has been doing a lot of work on that, and it's not a surprise to anyone here. I will be sharing these slides. Here are a few other great resources for policy recommendations. There are lots of great reports on this, these included, and I'm happy to take questions. Thank you, everyone.
Thank you, Doctor. Questions, comments? Savita?
Yes, good morning. So thank you to the two presenters. They were superb. Dr. Barnett, thank you for your presentation. So you raised so many great points, and I wanted to ask you a question. I have two questions, actually. I've recently heard another presentation, and they were saying, you mentioned poor retention, poor access to buprenorphine and people falling out of care. And that presentation I had listened to said that the groups, the Black, Hispanics, whites, folks would rather have that same presentation in terms of providers to be able to see them because they understand them better. So what that presenter was saying, that a Hispanic person would prefer, if given the option, to see a Hispanic provider, as would a Black person would prefer to see a provider who was also Black. There's a commonality, there's a sense of comfort, there's a sense of living the same experience, if you will. And I was wondering what your opinion is on that, if you think it makes a difference.
Yeah, I think, there's a pretty deep literature on like racial and, identity concordance between providers and patients, and that people are more likely to trust and connect with a provider who they identify with by race or other factors. The sad truth is we don't have very many Black physicians or Hispanic physicians, but we do have, but it could be much easier to recruit other staff like recovery coaches and other team members who overlap. And so I do think that minority providers, who are not necessarily minority serving providers, are also going to be a key part of this. And we all have a lot of incentive to try to train a very diverse workforce. I think this is yet another reason why that's important. But we also have to recognize that changing the racial composition of the workforce is like a decades-long policy initiative, whereas I think probably lower hanging fruit can be trying to work with the providers we have, as well as building teams that are, or incentivizing them to build teams that include people from the community that they serve.
Thank you. And my second question was, has there been any consideration in changing or adding to the medical school curriculum in terms of addiction, recognizing the stigma, asking questions, helping future docs have a different perspective with respect to OUD and treatment and such?
I do think that younger doctors are better about this, and they're much more accepting. Again, speaking to kind of the workforce issue, we do have a problem, which is that 80% plus of the workforce is going to be trained in kind of 15 plus years ago, in times when it wasn't really a part of their kind of medical adolescence, I guess, with kind of their medical training. And also, while I think that's really important, the culture of an institution or a practice is set by the most senior members, and also for health systems. So for example, like, you don't see health systems in Massachusetts, tripping over themselves to offer more addiction services, right? And it's not viewed as like a very prestigious thing to go into addiction medicine. And I think those are kind of institutional level stigma. A lot of it has to do with payment policy and kind of historical views of like what isn't prestigious. And so my point is more that, yeah, younger generations are doing better, and we still have deeply seated structural stigma issues to work through, and need to kind of also recognize that institutions, what they believe in is manifested in the services they provide. And a lot of institutions in Massachusetts don't provide only a tiny fraction of the addiction services that they provide for cancer or cardiology or sports medicine, or lots of other things that are arguably important, but not killing thousands and thousands of people, every year.
Yeah, hard stuff. Thank you. Thank you.
Other questions, comments?
I just had a quick thing. I just want to get your opinion of this, doctor, because it's kind of just striking me as you're going through the study. Because I think sorry for my light. I think a lot of what you're talking about is not new. Like, we've seen this disparity within the treatment of people of color in the medical system, right? I think we can all agree on that. But my issue is, are we using the right language? When we talk about stigma, but the last statistic that you gave in one of the hospitals here in Massachusetts, with the majority of patients that go there are Black and brown people. We're not, as you said, we're not changing the workforce to have more doctors and practitioners of color overnight in those institutions. So why aren't we using words of racism? Like, it's very specific that these people just are not getting the same level of treatment as to white patients. So, because I think when we see all these big settlements coming out of like Purdue Pharma, all these big opioid settlements that are coming out, I'm wondering, are we using the right language to make sure that perhaps some of those millions of dollars that we're using are going into these medical professions, are trying to educate these hospitals and make it clear the disparities that they're causing because of the way that they are interacting with the community that they serve. So I'm just wondering, one, what has been the medical response, if you've gotten any, to this? And two, are we using the right language when we say stigma or bias with the hope that we can change people's heart and minds, as opposed to what it is and what the data is showing?
Yeah, so thank you for calling out, the fact that yes, a lot of this can be easily labeled as structural racism or just blatant racism in the system. And obviously these problems are very complex, and part of the issue is also, I guess this is me, for institutions, we also need to have policies that incentivize them to make more substantial investments in these areas that are not going to be profitable and going to be serving patients who they're not trying to seek, as opposed to just window dressing and just saying, yes, we have a director of DEI, but we're happy for a vastly disproportionate number of Black patients to be seen at that other hospital. And there are not easy solutions to that, but I think that I do think that's where a lot of the structural racism emerges, is the segregation in the city, the difference between Medicaid reimbursement and commercial reimbursement, and the kind of economic dynamics of providing healthcare in this environment. So hopefully that's kind of an answer to your question. I guess what I'm saying is this is racism, and it also manifests, I think, in kind of some of the deepest realities of healthcare, of what is profitable and what is not profitable, and where institutions choose to locate and where they don't locate.
Great, thank you.
Doctor, could you go back to slide 8? I just have a question on, so does this show that obviously the buprenorphine and methadone are being distributed more, but the disparities still exist? Is that what it demonstrates?
Yeah, well, I guess this is responding to, I mean, for people, for like kind of the for like the scientific reviewers of this paper, they'd say, well, the common wisdom is that Black patients are much more likely to get methadone than white patients. So maybe the reason we're observing this is because Medicare during this time doesn't cover methadone. And so we're just, and buprenorphine and methadone are good substitutes for one another if we take out the whole OTP, the whole, kind of probationary nature of getting access to methadone. Just think of it just as people getting any service. And so it could be that like this actually evens out for access to opioid agonist therapy if we consider both together. And that's not the case here. If it were the case, by the way, it still would be problematic, because we know that access to methadone, the biggest issue is not coverage. It's that the methadone distribution system in this country is really more based in a philosophy of corrections than a philosophy of treatment and healing. And that was explicit, and the program began in the 1970s as a way to lower crime rates, not as a way to provide, let's say, sympathy and goodwill towards people with addiction.
Thank you.
I just wanted to comment really quickly. I was over here like a bobblehead. I really enjoyed your presentation. I'm embedded in primary care, and I'm a social worker. And just even getting my 50 somewhat primary care physicians to prescribe MOUD is a challenge in and of itself, regardless of, the patient. The work that you've done here is really important. And I just, it's a challenge in and of itself. They're willing to prescribe these high dose opiates, and then have reasons for not wanting to get themselves on board with MOUD. So.
Yeah, practice level change is a big topic in primary care. And one thing I can say is that a common theme in practice change is like that, practices really needs like a champion, like a person who really cares about the topic, to really try to galvanize and lead other people. And doesn't necessarily have to be a physician. But, it sounds like you're a part of a big group. And, if there isn't a champion in your practice, that's like, that's the kind of thing that's very unlikely to change. In some ways with like almost any new medication, but buprenorphine has the problem that it also has all of these layers of social cultural stigma, racism built into it. And a lot of doctors, whether it's explicit or implicit, they may be just not that interested in actually really engaging with their patients' addiction problems. They want to see it as somebody else's problem.
Mhm.
Great.
But this brings back the issue that your patients with OUD can see the people in your practice all they want, but if the doctors are fundamentally uninterested in prescribing this, then it's not going to change. And so then a policy response is, do we try to change the way a lot of physicians are practicing, which could be possible, but it's honestly extremely hard? Or do we invest in other systems that can maybe be more specialized in providing this kind of care? Through, say, maybe more harm reduction philosophies, or locating in places where we know there's high rates of drug use.
Yes. Doctor, thank you. Thank you very much. And thank you for sharing the presentation as well. All right, moving to our next speaker, we're happy to have Teresa Harmon, who is, as she said, a licensed independent clinical social worker as well as a nurse. And Teresa is the founder and executive director of To the Moon and Back. I just love the name of that. But it is a nonprofit organization that works to support education and advocacy for children who are born substance exposed and their caretakers. And completely separately, I had the opportunity, which we put in the chat, to see just a really moving piece on Channel 5 that was done about the program. And Teresa's joining us today to share information about neonatal abstinence syndrome, what it is, the signs in infancy, and the work that To the Moon and Back is doing to help members of the community. So, Teresa, happy to have you here this morning.
Thanks for having me. Can you guys see my slides?
Mm-hmm.
Perfect.
Yep.
All right. Whoops. You had to have me follow the guy who knew exactly what he was doing. Here we go. Background wise, so we started our nonprofit back in 2017. We're a board of volunteers based here in Plymouth, Mass. We got our funding. Actually, we started primarily, a lot of our funding came from the Plymouth County DA's office. We built our program. It started with my son, who we had taken home from the NICU. My background was as a clinical social worker. I had worked in child welfare, and my son was born opiate dependent. We adopted him at 10 days old, and I kind of knew what we were getting into, but back 11 years ago when we first brought him home, we didn't know quite as much as we do now about NAS. And so around when early intervention ended, we found that we just really weren't getting what we needed for him. And so the research hadn't caught up with him. The providers that usually turn to couldn't really tell us what we were seeing with him. And so, like any social worker, we decided to develop what we needed for him. And so just to kind of give you guys a quick background, if you don't know what NAS is, it's typically talked about in relation to the withdrawal syndrome that babies go through at birth that have been exposed in utero to opioids. So it's the full-blown withdrawal syndrome. And then there's prenatal opioid exposure, and that is when kids are exposed in utero but don't necessarily go through the withdrawal syndrome. And you can have NAS with some other medications, but you don't go through the significant syndrome except with opioids. And so, and those can be prescribed, or they can be MOUD, Suboxone, Subutex, methadone. And so this is a diagnosis of infancy, and usually it lasts up until about 8 months. And after that, these kids receive services based on another diagnosis later. So like if they need services in school, they'll go on and need some other sort of diagnosis to be able to access those services. So this is kind of just a quick and dirty to kind of bring you up to speed if you don't know. So the symptoms that you see with these kids are here, but you will see things like hypertonia, which is, stiffness in their core, just a fancy word for stiffness, which can affect them later on with core strength, being able to sit and attend in school, sitting upright, being able to hold a pencil, and being able to have those fine motor skills to be able to write. Kids may have tremors. They have often irritability. Often that's from their sensory systems are affected from their exposure. That high-pitched cry that you'll often see in the news in reference to these kids. In very, very small subset of these kids, you'll sometimes see seizures because these kids are so well controlled on either medications or just interventions in the NICU. They can have diarrhea, poor feeding, so these kids are essentially going through the withdrawal process that an adult would go through. So that's just to give you an idea of what these kids go through at infancy. And nowadays, depending on how bad their withdrawal is, they will get either methadone or morphine to help wean them off of the opioids that they were exposed to in utero. And there's a new, well, it's not very new now, but there's a scoring tool that is typically used here in Massachusetts called Eat, Sleep, Console. And that scoring tool helps the providers and families decide whether these kids will receive additional opioids to help wean them. But they try to use non-pharmacological interventions to help keep kids comfortable and to expose them to as little additional opioids. So that's kind of where we came in because they were doing all this fabulous research and interventions for these kids in the NICU, but they had kind of left off there. We as parents, through our nonprofit, had gotten together and said, okay, like now what? Because our kids are still, really struggling. They're struggling in school, they're struggling in the community. We're seeing like a lot of the same needs for our kids, but nobody's really doing any research on them. And they need more. As parents, we didn't have anyone that was really helping us. And so we put together services for our kids based on the unmet needs for our kids. So that involved support groups. We started running child play groups for our kids so that they could get together. This was 7 years ago. So now, our kids have had these things in place for them for years now. We put together financial resources for things that weren't covered for our kids. A lot of times that was sensory toys that they might need, or uncovered co-pays and things like that, because a lot of our kids are on mass health and we needed mass health providers to get them into services. We did like a we do an annual conference where people come from across the country to come get together to hear, about new research on our kids, or to meet with providers that have specialization in the areas that our kids struggle with. We have a children's book that talks about what it's like being a child that is growing up with NAS, to start that conversation with kids about, what it's like having this condition, because we were like, well, how are we going to have this conversation with our kids about what, you know, what has occurred to their brain. We have an educational advocate that's able to provide free advocacy services for families. We have a variety of services to kind of catch these kids. And then last year, we did our own research study with Child Trends to advance the study on these kids that was lacking. And so this is kind of the outcome from it. So it was a smaller study. We had a little less than 200 kids, but it looked at kids here in Mass, West Virginia, and represented 21 other states. The majority of the kids were white. There were some that were Hispanic, Black, multiracial, as you can see here. Average age was 5 years old, and it was mostly adopted parents, relatives, and non-relative foster parents. Unfortunately, we didn't have a lot of response from parents that were still parenting their children. And I'm going to skip over a lot of this because I know we don't have a ton of time. But what we found, one of the things with the research that was already out there was that a lot of times people would say that it wasn't opioids that was affecting our children, that it was other drugs, it was alcohol, it was, trauma. So we did very carefully control for that. So we controlled for trauma, we controlled for other substances, and what we found was that when we controlled for those things, that these kids still had very significant rates of developmental delay, behavioral health needs, learning concerns, and educational needs. We did not compare them directly with their peers, but as you can see, in our cohort, 63% of them had a developmental delay. So, even just thinking about the general population, you're not going to find in the general population that 63% of kids have a developmental delay, or that 45% of them have a behavioral health condition. 49% of them have more than one diagnosis. Overall, families, and this is 80% of these kids had early intervention. So this is beyond and despite having early intervention services. So while those services, parents said, were some of the most important and beneficial services that they had, they still were not enough. And families are very vocal about feeling like they were out there on their own, that they felt like it was a real struggle for them to get what they needed. You can see with some of these comments what some of their struggles were. These were some of the behavioral issues that they expressed to us. Kids were impulsive, they had tantrums, transitions. As the mom of two children that were born with NAS, I was often told that I was just experiencing the terrible twos or the terrible threes. However, I'm a clinician. I knew that what I was seeing was not just typical child development, but I was still just, not listened to. So if you can imagine what that's like for a parent who doesn't have the backing of a master's in social work, or, a nursing degree, what that feels like. And having to try to advocate for your child with a condition that is not, even now still fully understood. pretty hard. And then now couple that with being a parent in recovery, trying to get services for your child and trying to, you know, keep yourself well. We also looked at the strengths of these kids. You know, one of the things I point out to people is that although we'll never know what these kids' IQ would have been, obviously, they're not like, you know, kids with FASD. Their IQ is not affected. These kids are very smart, which can be a challenge because they're very smart and yet their processing speed can be affected. They're, you know, they're very mindful in many ways that they are, that they can be different and that they can have challenges. They're very empathetic. They can have really great social skills, but sometimes some of their other challenges, when they're focusing on all these other things that they have going on with them, can be affected. And they're very resilient. You know, some of the things that we see are high rates of autism for these kids because their executive functioning skills are affected. They have sensory processing differences, very high rates of our number one diagnosis is ADHD. And we see a lot of what's called ARFID, which is avoidant restrictive food intake disorder, which is an eating disorder. Our kids struggle with eating. They also often have eye disorders, strabismus, nystagmus, and what's called CVI, which is a cortical visual impairment. It's a neurological eye impairment. So these kids, you know, they have these physical impairments as well. So even though 80% of our kids were in early intervention, you'll see that only 39% of them went on to have an individualized education plan. So this is an area that really needs to be worked on because if 80% of our kids needed EI, it seems rather odd that then only, you know, 39% of them needed services in school. They didn't just magically all of a sudden not need any additional services. So that's an area that needs to be worked on. And then, you know, as with many kids and, you know, even many adults, mental health counseling was very challenging for these families to access. These were the services that families felt were helpful and unhelpful. They felt that pediatricians didn't listen, that they didn't refer them where they needed to get to, and they didn't feel that schools were helpful. And you know, some of the words that families used, they felt like it was a fight, a battle. So that's kind of what our research study found. And then just to kind of, so definitely look at our website for the services that we provide. We did just receive a number of grants. We have one with the town that we just received so that we're able to provide care coordination for the town of Plymouth, any families that have a child with prenatal opioid exposure. So we'll be able to follow any child from 18 and under that has a diagnosis. And then we just received $1 million in funding from the state for the next 5 years to, they wanted to implement something within one municipality. So it is, again, for the town of Plymouth. We'll be working with the Plymouth Public School System. We'll have an embedded clinician who will be working within the elementary school to provide interventions for kids with prenatal opioid exposure. And our scientific partner at Child Trends will be studying our interventions. There's no best practices in these for these kids as they grow older. So we'll be developing evidence-based best practices for these kids as they get older, to hopefully roll out nationally for these kids from our tiny little nonprofit here in Plymouth. So that's what we do.
That's a pretty impressive array. Questions, comments?
I know I hit you with a lot.
You know what? Oh, there we go. Okay. Carol, do you have a question?
Amazing, inspiring, and thank you, thank you. Quick question. I'm on my local town board of health, and then I work with 4 towns through underage substance use prevention grant. Do you support communities who may be teaming to how to spend their opioid abatement funds and share this incredible information to connect the dots as related to the harms of opioid use?
Yeah, sorry, and I should be clear. So although we're based in Plymouth, we provide services for the entire state, actually really the entire country, because we're the only nonprofit that does this work. So we are able to provide, and we always have, we provide training, consultation. We work with any families across the entire state.
So thank you, Teresa. I'm thinking of, data, how to connect with families or grandparents or folks that are loving and supporting children with NAS. And then, so the answer is yes. And I'm going to look at your website and keep your name, because this is exactly people with lived and living experience, what the funds are intended for.
Yeah, anything we can do, whatever, if you want to collaborate, we're happy to expand. We're happy to help you write a grant to do the work and to offer technical assistance, whatever you want it to look like, we're happy to support you.
Thank you. Thank you.
Sabina?
Yes. Hi, Teresa. First of all, what an incredible human gesture for adopting children, having this knowledge. You're a wonderful human being. Second of all, the work that you're doing is astounding. I'm wondering, do you partner with the hospitals that either children's hospitals or other hospitals that where babies are born, to sort of give this opportunity and to sort of give them all the resources to at least help them kind of navigate somewhere? And is there somebody who kind of partners with that mother? And I know that's enormous work, but to sort of keep an eye on them, like, check in every week, every month, and say, where are you at? How can we help you navigate through this?
Yeah, so we got our start at the same time as the SOFAR clinic up at Boston Medical Center. So we work very closely with them, as well as the Hope Clinic at Mass General. And we provide these take-home boxes that we curated kind of with them and with our families, with items for families that are taking home babies born with NAS at almost all the hospitals around Massachusetts. So, and also with, we send them from like basically anywhere that wants them. They don't have to be hospitals. So families get these boxes with like all these items. And then as far as First Steps Together and Moms Do Care have programs that work with families. Some of them work with them until 3, some of them work with families until 5. And they have moms with lived experience that go into the home and work with these families. And then those particular clinics, and there's some others kind of across the state too that do this work, trying to keep dyads together, moms and babies. So yeah, there's definitely that work going on.
Thank you.
Anybody else? Questions,
I
comments?
just had a quick question, DA Ryan. Teresa, when on the slide that you showed with the IEPs, which was shocking that it shouldn't be shocking that they're that's low, but to your point where you said, you know, these children are not outgrowing the issues that they've had since birth. I'm just curious what language some of these districts are using as to why not supporting these IEPs, because it seems legally there is going to be, they're not meeting their benchmarks, they're not meeting their educational goals. So I'm curious about what some of the things you're hearing back as to why these IEPs are not supported or 504s. And then secondly, is it an issue perhaps of using some of the abatement money to go to attorneys that deal with special ed law and going in and advocating for kids, for these children?
Yeah, I think it's looking at it from a macro level, it's it's a really complicated issue. How do I say it nicely? So the research hasn't caught up with them yet. You know, the research to date has been very limited. The medical community has been very hesitant to say that there are long-term consequences with these children without the research, but the research has been real slow. A lot of them will say, you know, I don't want to start, another crack baby epidemic or whatnot. And then there's the challenge of stigma. You know, they have a hard enough time getting moms, they tell me, onto MOUD. And I think, worry that if they talk more openly about some of these long-term consequences, that moms may be more hesitant to get onto MOUD. I mean, this is the only drug that we treat with more opiates. With every other drug, you try to get a parent off. With this, there is potential, if we were to get a mom off of the opioid that she's taking, that she may abort the baby. And so it's kind of a very complicated issue. And then there's the stigma too of, moms thinking like I've done some harm to my child by taking MOUD, but the reality is that by taking MOUD, they're really doing the best for their baby. So, I mean, in my mind, the best would be to do some, education to mom and to the, socially to the community, to explain to people that taking MOUD is helping everyone in this situation, and that these kids are going to be born this way, and that's got to be okay, and that there's things that can help them. It's a really complicated issue.
Right. Anybody else? Thank you, Teresa.
One quick upcoming event on August, the last Thursday of the month at 6:30 at night. Woburn is doing its vigil on the Common. It's a couple of speakers and presenters of people that have lost their kids to this drug. I'll be having a display once again for my second year doing it. It's going to be the xylazine and the fentanyl test strips, courtesy of DA Ryan. So I thank your office for that, along with a lot of paraphernalia from the Mass Department of Health. So it's free. Anybody can go down and visit, check out a couple of the displays, and it's a very nice candlelight vigil. Again, that's 6:30 in August, the last Thursday of the month.
Thanks, David. I will just point out for people who are interested, as many of you may have seen tragically over the last year or so, we have had a number of children in Massachusetts on the autism spectrum who have drowned. And, I've said from the beginning, that's been one of my targets, is any child drowning. That is a completely preventable situation. We are going to be offering some programs with respect to swimming lessons and safety lessons for parents and kids on the spectrum, and that's going to be the 14th of August. So anybody who's interested or who wants to get the resources, please reach out to us. You can just reach out to our website, or email up, message Nancy or any place, and we'll get you the information about that. So I want to thank everybody for being here today. I want to particularly thank our speakers for great information, and we will see everybody on August the 15th. So thanks so much. Take care. Bye-bye.